Welcome to today's session in our K through 12 Outreach Learning from Latin American series. We are really glad you are joining us today. Dr. Ruben Hernandez Leon, the director of the LAI, will not be able to join us today because he had a conflict of schedule. Today's conversation invites us to think about how care is measured and governed and how data gathering tools shape in what becomes visible and what remains silent, unseen. It is my pleasure to introduce Dr. Gabriela Elisa Morales, Associate Professor of Anthropology at Scripps College. Dr. Morales is the author of the book Decolonizing Medicine, Indigenous Politics, and the Practice of Care in Bolivia. Today, she will present her talk, Seeing Like a State, Caring Like a Survey, Health, Kinship, and Data Gathering in Bolivia. Dr. Morales will take questions at the end of her talk. Please feel free to send us your questions in the Q&A box as they come to you. Please join me in welcoming Dr. Gabriela Morales. Dr. Morales, the floor is yours.
Thank you, Vero, for that kind introduction, and to the UCLA Latin America Institute for hosting me today. So I'm going to go ahead and share my screen and get started with the talk. Here we go. All right. So today I'm going to be speaking about my research that was presented in my recently published book, Decolonizing Medicine, Indigenous Politics, and the Practice of Care in Bolivia. But I'm going to be presenting just one small slice of what is actually a much larger book project. So this mostly comes from one of the later chapters of the book and is primarily about practices of surveying and data gathering in rural healthcare, but also in thinking about kinship and different ways that we think about care in general in medicine and beyond. So I'm going to just start with a short scene, a story for my research. So early one morning in 2015, I accompanied a small group of NGO staff members as they drove down a dirt road that cut a straight, narrow line through fields of quinoa on the Bolivian Altiplano. Despite the early hour, the sun was already beating down, creating a contrast between yellow fields and a bright blue sky. Finally, the NGO truck stopped in front of a mud brick house at the edge of a village. An older man, his face weathered from the sun, his sweater and pants flecked with dust, was raking up hay for the large black cows standing at a distance. He set down his rake and looked at us curiously as the truck pulled up in front of him. Mariela, one of the NGO staffers, got out of the truck and greeted him. Shaking the man's hand, she told him that she and her colleagues were helping providers from the nearby hospital fill out household surveys for each of the households in this village. She asked if he would be willing to answer some questions so that the medical practitioners could work to, and I quote here from her, to better the health of the community. The man, named Paulino, sat down on a bushel of hay and nodded in agreement. I was holding the stack of blank Ministry of Health survey forms, and Mariela took one from me. So I'm going to show it here, but I'll return to this later as well, so because we're going to go through it rather quickly. So Mariela began to go down a lengthy list of questions. How many people sleep in each room of your house? How do you dispose of waste? How much grain, meat, fruits and vegetables, oil, and iodized salt do you consume every day? Does anyone in your family have an illness? Do you ever visit traditional healers? Like many village residents we would meet that day, Paulino responded to each question in a way that emphasized his use of biomedicine and his preoccupation with health. His family ate a varied and healthy diet, he insisted. He never went to see a traditional healer. So during the presidency of Evo Morales, he's often described as Bolivia's first indigenous president. He was a campesino and a coca grower, union leader of Aymara descent, who was elected in 2005 and became president in 2006 at the head of a party called the Movimiento al Socialismo, or Movement Towards Socialism, just more commonly known by its acronym, the MAS. And he governed from 2006 until his ouster in 2019. So during his presidency, the Bolivian Ministry of Health officials undertook projects to, as they describe it, decolonize the national healthcare system. My book, Decolonizing Medicine, Indigenous Politics, and the Practice of Care in Bolivia, which was published last year, examines how these health reforms brought together approaches from Latin American social medicine and indigenous anti-colonial struggles with the goal of building a public healthcare system that would better serve Bolivia's majority indigenous and low-income population. So policies undertaken in the name of descolonización, which is the term that they use. So it's not my term. It's actually the policy. Decolonization is the policy term that many Bolivian officials used. Were quite wide-ranging. They encompassed projects like training biomedical practitioners to be more culturally sensitive, particularly in a context where the majority of the country identified as indigenous, integrating traditional medical practitioners into clinical care, providing what they called culturally adapted options for childbirth, and sustaining community participation in health planning. So, in this talk, I focus on just one specific aspect of these wider decolonial healthcare reforms: the development of household surveys, which were known as carpetas familiares, or family folders, which, again, it also forms the basis of a later chapter in my book. So the carpetas, as they were just often called, were designed to help biomedical practitioners move beyond individualizing models of treatment and to pay attention to the socioeconomic factors that shaped the health of patients in the communities that they served. Policy reformers who enacted a new policy called the Family, Community, and Intercultural Health Policy, usually known by its Spanish language acronym, the SAPSI, in 2008, explicitly drew from multiple inspirations when framing the adoptions of the carpetas as a key strategy for improving care. Um, so, First, I would say they heavily engaged in global health policy frameworks of what are sometimes called the social determinants of health. If folks are familiar with that term, it, the WHO would define it on its website as social determinants of health can be broadly defined as the conditions in which people are born, grow, live, work, and age, and people's access to power, money, and resources. Reformers also drew really heavily from a policy and activist movement known as Latin American social medicine. And so it's essentially a hemispheric movement to center the social dimensions of health and healthcare, and usually emphasizes the addressing of socioeconomic factors that underpin health and illness, investments in primary care and preventative healthcare services, and also sustaining the right to health through projects like universal healthcare. Finally, another a key influence, which should be clear in the government's use of the term decolonization, is Andean decolonial theory and indigenous relationality. So there's a lot of ways to think about this, and I'm really not going to be able to do justice to them in this talk. But I will say that broadly, what indigenous thinkers and activists who sort of influenced the Morales administration put forward was the notion that health and well-being are shaped through relations with human and non-human other beings. So when I say non-human, I'm referring to potentially elements of the natural world, but it could also include entities like ancestral spirits, sentient mountains, and so on and so forth. I would say forms of thinking about this that were especially influential for the Morales administration were especially the writings of Aymara theorists like Fausto Reinaga, who was writing in the 1970s and who wrote about indigenous knowledges and lifeways as alternatives to both capitalism and colonialism, and as well as more recent writings by thinkers like Felix Pazzi, Fernando Wanacuni on indigenous philosophies of good living and communal ethics. I kind of give you this background because I want to give you a sense of what were the ways that Bolivian health policy reformers were thinking, I think, in quite innovative and interesting ways about like how do we actually change the way we think about health and provide better care, especially when serving a patient population where many people do not have access to great hair care, where there are common practices, let's say, of racial discrimination against Indigenous patients, or just sometimes questions of money and being able to pay for care, or for patients who are living in more rural areas and simply did not have many options for biomedical care around them because there were just very few rural health establishments. Um, and so, while their approaches shared many similarities with other global health projects and efforts around the world to try to center social determinants and say that, like, actually paying attention to these factors really matters for building a good public healthcare system, many Bolivian policymakers explicitly suggested that the shift from a focus on the individual to a focus on the social stemmed from indigenous cosmologies that situated well-being in what they described as relations with family, community, and nature. So they positioned this as a potential model for a more expansive and holistic model of health, one that would take into account people's social relations and move beyond models of medical care that focus just on treating an individual patient body in the moment and treating just the biological cause of disease, but instead sought to kind of shift the focus into more the context in which people would actually get sick. So initiatives like the Carpetas Familiares, according to Ministry of Health officials I interviewed, stemmed from this more relational mode of care, and basically with two main goals in mind. So one, as you can see here, was really to kind of center the social, material, and environmental factors that shaped patients' health. And the other was also to kind of bring medical providers into a closer relationship with the communities that they served, um, and to understand the problems of each household, particularly in like where were they facing challenges, potential health risks, and really be able to build up that provider-patient relationship. So, throughout my talk today, I'm going to talk about both the possibilities and the limitations of this model of healthcare, particularly as it was based in these household surveys and as it was implemented under the Morales administration's decolonizing reforms. So, drawing on research in a very rural, predominantly indigenous Aymara district, I trace how these surveys helped providers visualize community health in terms of broader risk patterns. But I also argue that the surveys framed risks to health as stemming primarily from patients' household and kinship relations. Um, and in doing so, they kind of went against the initial intentions, I think, behind the policy, which was really to expand all the ways that we sort of think about health, and really ended up kind of narrowing the focus just onto a very narrow set of social determinants. And in contrast to this view kind of put forward in the language and administration of the surveys, many Aymara patients themselves viewed kin relations, including kinship with providers, as central to sustaining their health. And paradoxically, and despite policymakers' intentions, the surveys distance providers from the more relational forms of care that patients, in fact, sought to cultivate. So I want to just kind of briefly frame my methods and how I approach this project. So um, I based this argument on 18 months of ethnographic research I conducted in Bolivia from June 2014 to December 2015, along with shorter visits in 2012, 2013, 2018, and 2019. This is all to say this research actually took place a while ago. Often sort of anthropology publication timelines take a while. So in the conclusion to the talk today, I will address a little bit what has changed since I did this research, but I just kind of want to flag that some of what I'm talking about today here is still in place and some of it is now a little bit outdated. So, as a cultural and a medical anthropologist, my research methods center primarily on qualitative interviews, participant observation, and a general orientation to understanding problems via long-term presence, careful listening, and building of reciprocal relationships with those who choose to participate in this research. So while I study healthcare policies, institutions, and systems, I approach these questions from a more humanistic and qualitative social science perspectives of centering lived experiences and what people have to say about the healthcare systems in which they work and in which or they receive care. So for this project, I spent roughly kind of the first 6 months of my long-term fieldwork stretch researching health policy making more in the administrative capital city of Bolivia, of La Paz. And I interviewed state and regional health officials, NGO workers, and attended many planning meetings. And then the next 12 months, so pretty much throughout the year 2015, I worked mostly in policy implementation in a rural, but I would say rapidly urbanizing highland town in the Andes of about 11,000 residents, again, most of whom identified as indigenous Aymara. The town was served by a small hospital that provided mainly primary care and emergency services, along with a handful of specialties. I also traveled to surrounding villages quite frequently. So, for example, when I would accompany biomedical providers and NGO workers on household visits, like in the story that I described at the beginning of this talk. I must say, it is often the norm in anthropology to provide pseudonyms to individuals and, if necessary, to institutions and places to protect those who participated in the study. And especially given the many infrastructural and resource challenges faced by the local municipal hospital, as well as just the sensitive nature of patient and practitioner experiences, I have chosen to kind of anonymize my study as much as possible, including people, place names, and institutions. So in this talk and in my work, I use the pseudonym for the municipality and the town of Machacamarca, and which is actually a commonly used place name of numerous towns and neighborhoods across the Altiplano, so it's not particularly unique. And so that's the name I'm going to be referring to throughout this talk, although again, it is a sort of fictitious pseudonym. But I do have on this map kind of just highlighted the broader region where I was working in case that's helpful. So, as I've noted, when Bolivian policymakers talked about situating health in relations with the family, community, and nature, they were essentially inspired by a long tradition of Aymara anti-colonial activists who positioned Andean indigenous conceptions of reciprocal relations and kin-based political organization as central to sustaining a good life. Activists, as well as the policymakers who adopted their frameworks, explicitly situated Andean indigenous modes of relation in contrast to the violent extraction of both colonialism and capitalism. Yet, as bureaucrats worked to convert these activist projects into actionable policies within an existing healthcare system, they also watered down what were initially quite radical proposals and the potentials of these frameworks in two key ways. So, first, in treating Indigenous relationality as equivalent to a broader focus on social determinants, kind of more in line with this global health framework, they erased the situated specificity of ethical practices that constituted health and well-being. And then, second, and relatedly, household surveys extended mechanisms of surveillance that treated family as a predetermined entity that was bound by biology and location within the household. So, in doing so, they ignored patients' own formulations of kinship, including those that brought biomedical providers into relations. So, in the municipality that I give the pseudonym of Machacamarca, where Paulino's village was also located, people often sought to bring medical providers into relations of material exchange and compadrazgo, which might be translated into ritual co-parenting, to facilitate healing. So, echoing forms of patronage and clientelism that are common in many contexts in Latin America, compadrazgo often involved asking someone with relatively greater resources or perhaps a relatively greater position of power to become kin. So, although that was not always the case, especially when asking medical providers, there's often some kind of social and economic differential between the person asked to be the godparent and the person who's doing the asking. Um, So in the Andes specifically, compadrazgo involved building long-term kin relations, not only between godparents and godchildren, but also between the parents and godparents who would often refer to each other as comadre and compadre. So I've kind of drawn this chart just for ease of reference if you're unfamiliar with this kind of kinship system. So basically, the idea is the parent is the comadre or the compadre with the godparent. And then also the godparent is the madrina or the padrino of the child, who they're the godparent to. So in Chacamarca, residents would actually ask medical practitioners, anthropologists like me, school teachers, politicians, and slightly wealthier neighbors to become kin. And I'm happy during the Q&A to also talk a little bit more about my positionality in relationship to this project, and in particular, how I was pulled into these kin relations and how they shaped my research. Um, so one might ask others to become godparents for the baptism of the child, which might be kind of more familiar to an audience in the US, but also for significant life events like graduations and weddings. So one might even become a godparent of an entire graduating class. This meant that both the child and their parents could have multiple kin relations forged through compadrazgo. And kin ties were enacted through ritual and material exchange as families brought godparents with, provided godparents with food and drinks, and godparents would provide gifts and sometimes money as well. In the context of medical care seeking in Machacamarca, compadrazgo facilitated a kind of ethical accountability from biomedical providers in a context where care was particularly precarious, where resources were few, and where patients often complained of neglect and mistreatment at the hands of providers. Bound by ties of compadrazgo, patients called upon providers to fulfill obligations to them by offering more personalized attention and facilitating access to medical care over the long term. So, for example, my neighbor in Machacamarca, Rosa, who nearly 20 years ago had asked one of the local hospital doctors who would regularly do household visits to her village to become a godmother to her son. Years later, after the doctor had left the rural municipality and moved back to the city of La Paz, Rosa ended up calling her to ask for help. Rosa's nephew was sick and needed surgery in a specialty hospital in the city. Rosa called her comadre to find out if she had contacts in the hospital who could help move up the surgery. So, care in this instance was not an immediate interaction of diagnosis and cure, but a longer commitment that could be deferred and then taken up again when needed. So in Machacamarca, kinship and exchange practices enacted long-term, sometimes incredibly laborious forms of mutual accountability across sometimes deep social hierarchies. Bringing biomedical practitioners into relations of kinship and exchange likewise did not really entail getting rid of those hierarchies. Instead, they sought to facilitate what anthropologist Marika Winchell has described as morally appropriate enactments of authority. And she also writes very heavily about sort of kinship and exchange, especially across hierarchies, in ways that I take up also in my work. And that have sort of shaped my thinking here. So, habituated forms of care practice could work to maintain existing social orders while also reconfiguring them to create an ethical ground for accountability, solidarity, intimacy. People didn't really make this one-to-one calculus that asking a biomedical provider to become kin was a mean to gain access to medical care in the moment. Instead, they expected that as part of relations of obligation, people would just kind of do the right thing and enact their moral duties as they emerged and if a situation came up. So for hospital staff, especially to be asked to be godparents, they already had to exhibit what people thought of as good qualities to be the kind of person one might want to be kin. So such judgments about who was a good medical provider and who was not bridged multiple kinds of expectations. Practitioners had to show attentiveness and generosity, but often had to have a certain social status. So, especially in the context where I was working, it was more common to ask doctors and especially male doctors to become godparents. But there were some exceptions. So, if you had close relationships with nurses, there was one nurse who had lived and worked in the town for over a decade, who was godmother to many children. But it was often the doctor who became a kind of renowned authority figure that people would sort of seek out. Um, in Machacamarca, people often recounted, for example, that a doctor I call Mauricio, again, that's a pseudonym, was one of the best doctors in the hospital. A gregarious general medical practitioner. He um, he was from the eastern lowlands of Santa Cruz, so would often kind of speak quickly, joke around with patients. He sometimes attempted to learn a few words in Aymara, but usually people would tease him about it. And unlike many practitioners I came to know who transferred out of the town after a few years when they could find a job in the city closer to where they wanted to live, Dr. Mauricio had actually lived in this rural town for over a decade. So when I accompanied him during his shifts at the hospital, he took a long time attending to each of his patients. In between shifts, he would sometimes take phone calls from prior patients or attend to them even outside regular clinic hours. Other hospital workers would express frustrations because he would take too long when seeing patients, and they argued that he was easily distracted. Yet many patients sought him out as a person who might grant them the sort of attentiveness that they otherwise wouldn't get in a kind of very unstable medical context. And according to what people told me, Dr. Mauricio was one of the few general medical practitioners they actually considered to be de confianza or trustworthy, which set him apart from many other providers working at their local institution. Some years ago, people would tell me there had been more doctors who they considered de confianza working at the hospital, and they would kind of ring off a long list of names for me, but lament that the municipal government had not paid these doctors enough, prompting them to leave for better jobs in the cities of La Paz and El Alto. So even now, people would recall these doctors with nostalgic affection, recounting how such and such was un buen doctor, so a good doctor. And most practitioners who were asked to become kin agreed to do so. Often they were asked when they had already come to know patients fairly well. And it was also another means for them to kind of gain respect in the community. So Dr. Mauricio, for example, would speak of the many ahijados or godchildren he had around Machacamarca. But I will say this practice also sometimes encountered limits as a site of transforming medical care and making it work better for patients. Kin work could sometimes be onerous and require continual presence. For example, if you were a godparent, you really need to show up for celebrations, sometimes pay for gifts, continually contribute time and labor and attention in the long term. So, for example, when I returned for a follow-up visit in 2019, my neighbors were actually really furious because they had asked Dr. Mauricio to become the godfather to their younger son. But on the day of the baptism, he had forgotten to show up. So they were quite angry about that. So STS scholar Max Liboiron, citing Cree researcher Sean Wilson, argues that accountability is a key site of ethical practice. And in many Indigenous communities, fulfilling a role and obligations is a way to be accountable to one's relations. So, for my interlocutors expecting biomedical practitioners to fulfill long-term obligations in their role as godparents was a way to create accountability, especially in a context of uncertain medical care. Yet, again, echoing Marika Winchell here, such localized forms of ethical accountability were also sometimes challenged by the Morales administration. Hmm. Um, which, while it did adopt many sort of projects of indigenous anti-colonial activism also continue to adhere to particular kinds of institutionalized liberal paradigms that emphasize the need for equal rights and equality and access to care, and saw this demand, this kind of practice of personalized relationship and favors as running against that. So under these paradigms, officials are positioned these sort of practices as quite um, antiquated, backwards, as running contrary to goals for equality for all. And so I point to how, in the realm of healthcare, household surveys erased these kinds of localized forms of kinship that brought patients and providers together and basically reframed kinship as a more biological tie and a site of potential health risk. So that said, I'm going to return to the survey over here. So, with the introduction of household surveys, Bolivian policymakers sought to introduce quantifiable ways for primary care providers to study social determinants and rethink their relationships to communities they served. So, acknowledging these problems of unequal access to care and distrust between patients and providers, policymakers emphasized the importance of strengthening ties between providers and patients. And while scholars have sometimes, pointed to bureaucratic documentation and these kinds of surveying practices as primarily producing different kinds of indifference, anonymity, or maybe even kind of foreclosing a care relationship. These carpetas, I suggest, were in fact designed, or at least intended, with the to augment and improve care by making providers attentive and aware of patient circumstances. So basically, the idea was like if you're visiting every house in your district, you're talking to people, you're filling out the survey, you're getting to know them, and you're getting to know what their health problems are, and that's going to make you a better, more attentive provider. That's kind of the underlying logic behind some of this. But in practice, biomedical providers and NGO workers were often overburdened and didn't always have time to go to each and spend time with each and every household. And so they would often go quite quickly through these questions on the surveys and use the form's numerical guides to understand how social dynamics, especially as they related to household and kinship practices, influenced health. So, for example, after finishing Paulino's survey, Mariela took a few minutes to fill out the remainder of the form before moving on to the next house. So, on the first page, she tabulated his responses to her questions to assess the risk level of his household. And the form assigned a numerical value to each response. So families who slept over with over five people in a single room, for example, were marked with 25 risk points. So that's kind of that top circle that I have up here on the survey, the number C on the form. And then but burning one's trash amount to 4 points, which was while burying it was worth three. So that's kind of the second middle circle on there. And then after filling out the survey, health personnel would add up the numbers from the responses. So 28 to 61 points was a low risk family, as you can see kind of at the bottom circle there. 62 to 126 was considered a medium risk family, and 127 to 165 was considered a high risk family. So after she had calculated the household risk level, in one of the blank squares on the first page of the survey, Mariela sketched out a rough map where Paulino's house was located in the village. So again, that's the top circle. And then the other blank square, she sketched out a kinship chart called the familiograma of Paulino's household based on his responses. Providers were expected to kind of sketch family connections using squares, circles, triangles, resembling these forms of kin mapping that had actually once really been common practice in anthropological fieldwork back in the day. Um, in addition to marking blood relations, illnesses, births, and deaths on the kinship chart, health personnel were expected to qualify the relationships between family members as close, very close, distant, conflictive, or ruptured, as shown on these instructions I've included up here. So, for example, you can see how they would draw kind of the close relationship with just a line and so on. A ruptured relationship would show the break in the straight lines connecting the family members. And so Mariana marked Paulino's family relationships with a simple straight line that stood for close, as she basically did for all the other households that she visited that day. Following this pattern, on the box in the second page of the form that asks surveyors to evaluate family behavior, like the comportamiento familiar, as either functional or dysfunctional, she checked off Paulino's family as functional. So I asked Mariela how she assessed whether a family was functional or dysfunctional, and she kind of paused, mulling over the question. And she suggested that dysfunctional families might include those where the father was absent. But in surveys she filled out that day, she marked the families all as functional in all but a few instances, a family in which the mother had died or one where the father had abandoned them. So, in the context of Bolivian carpetas, policy efforts to account for these wider social conditions and relations, which again kind of really stemmed from, this desire to move beyond just a focus on kind of individual or just biological causes of disease, but really think more extensively about people's social circumstances. But anthropologist Emily Yates Stewart reminds us that interventions designed to address the social determinants of health, even as they might come from a progressive desire to move beyond individual blame and pay attention to the social underpinnings of health inequality, they can also predetermine what constitutes both the social and health by offering, and here I'm quoting from her, prospective solutions that often do not result in the deep structural transformations that they claim to inspire. So the carpetas narrowly define the conditions shaping health through forms of documenting and seeing that centered on a very normative model of the functional family comprised of a mother, father, and children. It foregrounded a preoccupation with domestic practices like food consumption and how many people slept to a room. And kin relations were basically scripted as potential sources of illness that could be weighted numerically, as we saw on the chart. Um, so I suggest that this kind of way of framing things actually didn't come out of nowhere, but replicated longstanding racializing tropes that were prevalent in Bolivia and many other Latin American countries of the indigenous family as a site of potential deviance and pathologies. Where surveys described what was normal and pathological, not only in reference to health, illness in the body, but also in the family itself. So, numerous other scholars have shown that colonial systems historically took bourgeois intimacy within the private domain of the household as a primary reference point and basically sought to criminalize, regulate, and transform colonized subjects' practices of kinship, sexuality, and domesticity. And so the endurance of kind of this way of framing kinship, like, oh, that's going to be the source of pathology. Oh, that's the primary cause of illness. That's the primary cause of health risk. Would basically, foreclose the more relational understanding of health to which many policymakers aspired. It also bracketed providers off from the relations that many patients understood to shape their health well-being. So instead, patient-kin relations, which were understood primarily in terms of sort of just biological blood connection instead of something like godparenting connection, and located primarily in kind of a set household, became sites that needed monitoring for potential health risks. So efforts to create a sort of more holistic and relationally grounded care fell back into what scholars of indigenous data sovereignty have analyzed as dominant paradigms for data collection that rely on modes of asking questions, framing populations, and measuring processes and outcomes that reflect colonial presuppositions about indigenous peoples in Bolivia and elsewhere. Under such rubrics, data measurement and analysis can sidestep the historical and structural roots of health inequality and instead rooting damage within indigenous populations themselves. So, as literary scholar Diane Million puts it, and again, I'm quoting from her, large data descriptions of indigenous anomie eclipse the specifics and sources of our suffering, and perhaps most importantly, our specific strengths, silencing the narratives of our actual lives or the conditions of our actual deaths, end quote. Still, while these relations and practices were often defined as risky, their precise implications for health remained a bit indeterminate. So, for example, if we go back to the question of how many people slept in the room, it was a little bit unclear why that weighed more than something like burning trash, right? So in practice, the production of data about like how much risk each household was facing really remained contingent on providers' kind of own sense of judgment. Um, so for many providers, the surveys were often kind of this very burdensome, time-consuming task. In addition to the many other tasks they already had to take, they were all quite busy, quite underpaid. So hospital and health practitioners were already stretched thin, and sometimes the NGO workers, like the ones I was shadowing, would actually step in to just kind of help out to make sure the surveys got sent to got basically finished by the ministry deadline. And so when Mariela put close and functional relations as the default in most cases, she was reckoning really with what she did not or could not actually know of from a brief survey encounter. If she adhered to survey questions about family structure and household practices, she also just had to use her own judgment when engaging interlocutors, suggesting that most people she met were really not in need of any kind of special concern or intervention. But I will say this is also common to many forms of data collection, not just these surveys. There's a kind of central paradox where interpersonal negotiations and judgments are really essential for producing the data, but then the sort of more technical and coherent appearance of the finalized data kind of hides that very process and that indeterminacy. So after the surveys were completed, the Machacamarca Hospital statistician would enter them into a computerized database for the entire municipality. Under the policy, each health establishment was also required to create what was called a sala situacional or a situational room that would actually display the maps of the community risk levels and charts of health indicators on the walls of the room. Um, and so they would sort of develop these visuals. During my research, I sometimes joined the hospital providers as they would map the data by hand coloring the households on a map for each district. And so you can see some examples here. I've basically like just taken out the names of specific streets and houses and districts so that they're not identifiable. But you can kind of get a sense of like what these sort of mapping and charting look like. And then the bottom picture is just like where they kept the files that they filled out from each house on a shelf and colored it in yellow or green. In this case, there were no red charts, I think, on this shelf. That would have been a higher risk household. Um, but basically, tasks like coloring and maps and color coding files with risk levels encourage providers to basically care through and with these data sets, even as they also reckon with the kind of the limitations of implementation. So the purpose of creating a room like this with all these sort of like maps and visuals on the walls was in part to aid providers in visualizing the communities they served and be able to follow up with households in the future. And so, in the Bolivian context, state policies firmly linked the collection of population health data to care, positioning the surveys as a new mechanism of inclusion and a way for providers to better attend to patients' circumstances. Um, and uh, and basically insisting that providers were no longer neglecting communities as they were accused of doing in the past. And then simultaneously, they were also kind of designed to signal to patients and local residents that health establishments were attending to their concerns. So, like, hey, look, we've done all this work for you. You can actually visually see how many households we visited in this community, and it's very visually and striking and inviting to have these colored maps on the walls that people can just kind of walk in and observe. Um, but basically in practice, the hospital practitioners recounted no one had as yet used this data when treating patients or conducting follow-up visits. The surveys basically sat untouched on the cells of the sala situacional, and providers were supposed to return to visit kind of red and yellow, so high risk and medium risk houses more frequently. But those I interviewed described again finding difficulty finding the time and resources to do so. So, as with the connection of initial data, follow-up household visits were challenging to complete alongside other work responsibilities. And it was just difficult to mobilize practitioners with limited time and resources. Um, and so basically, as the collected surveys often just kind of sat on the shelf, the labor of data collection and display itself became the central mode of care. Yet for patients, answering the survey questions did not necessarily lead to greater access to health resources or to resource distribution in their favor. So on the day I accompanied Mariela, a few people asked if answering the survey would mean that the doctor would come treat them for medical problems. And Mariela always responded that while it would not lead to direct care, the data collection would help providers understand health issues to better the health of the community. So while policymakers and sometimes providers themselves position the surveys as a way of caring for patients, the carpetas also introduced many new challenges to building sustained relations. So in 2015, I interviewed Delina, a middle-aged nurse who had worked for about 10 years at a health post in a remote village. She described how she found villagers to be hesitant about receiving care, but that in developing personalized relationships with them, she had been able to build greater trust. Yet, once state officials started requiring health providers to administer surveys like the carpetas, Lilina found it more challenging to create this trust. So she remarked to me, and I'm quoting from our interview, the villagers thought that if the data is collected, they might have to pay more taxes or their lands will be taken. So for that reason, it was also difficult to convince them. Um, so basically, since since I undertook the study 10 years ago, a lot has changed. The carpetas remain part of health initiatives in Bolivia, with increasing moves to digitize them. There's also been some updates to the form. Last I checked, I believe this is a more recent version. So you'll see some of the ways that things are calculated have changed. And so there's kind of a little bit more potential, more breakdown of the different elements. But broadly, it's still kind of the same set of questions and things that they're sort of looking for. I will also add that in the most recent Bolivian general elections held in August 2025, Evo Morales' political party, the MAS, lost extremely badly. And Morales himself was barred from running for the presidency because of term limits, and economic frustrations as well as political infighting led to the erosion of the MAS's once dominant position. In October 2025, the runoff presidential election was held. The center-right candidate Rodrigo Paz beat out the far-right candidate Tuto Quiroga. So much remains to be seen about what PAS is going to do with healthcare policy and reforms. It's still quite new. And I will say, while many of the political initiatives I describe in my research may possibly be on their way out or changing, I do think it is nonetheless worth thinking through what Bolivian state-led decolonization entailed, as well as what its implications are for institutions' embrace of decolonial frameworks. Um, so for many residents of Machacamarca, as I have described, care practices really needed to be accompanied with long-term labor, material commitments, and accountability to others. Bringing providers into kin relations facilitated access to biomedical care. Um, but even if such practices were not just about, receiving better care in just that moment, rather, many people I interviewed understood such relations to be very meaningful sites of interpersonal relations and ethical practice that could constitute bodily relations, bodily health in and of themselves. Um, and good relations and exchanging food, drink, and other substances were really central to sustaining well-being in ways that were compatible with, but also not really reducible to a biomedical understanding of health. And such practices, by virtue of their situatedness in these kind of local relations, were really difficult to scale up to policy, which instead sought uniformity, equality of treatment, making sure that this sort of everyone gets their household survey filled out. Yeah, I would argue that attending such practices might also open up different ways of thinking about care. And I will just sort of leave us with the provocation that it might open up possibilities for understanding the social determinants of health, not through the sort of narrow lens of patient household practices, but as an active relationship that is co-constituted by both patients and biomedical providers. Um, so thank you so much. I will leave it there.
Well, thank you so much, Dr. Morales, for such a wonderful talk. And we'll now move on to the Q&A session. So please continue placing your questions in the Q&A chat. And as we get questions, maybe we can start with this one. Can you say more about how the Aymara understanding of kinship can complicate how the info in the surveys gets interpreted?
Sorry, the last part of the question was how it imped.
I'll repeat the question again. Can you say more about how the Aymara understanding of kinship can complicate the info in the surveys? How is it getting interpreted, the information that it gets put in?
Yeah, into the surveys. Yeah. Um, yeah, so it's interesting because I think the surveys were just in some ways very superficial. Um, so which I think was one of the what I would say one of the kind of um, challenges or shortcomings of this kind of sort of survey heavy approach, although, it kind of is designed to give a sense of like overall, like what's going on in a community, what are the main risk factors. But I think there were kind of, this is maybe a sort of roundabout way to answer this question, but I think there were sort of two main challenges that I think doctors themselves were sort of very aware of and would very willingly kind of just be open about. They were just like, this is not working as it's supposed to. And one was that like they themselves are super busy and overworked very often, and also not really trained in survey methodologies. That's not what a doctor usually has to do, or a nurse, or like any kind of medical provider. That's not their job. Their job is they're trained to heal patients, and they can also get to know patients and understand their circumstances. In my view, that's actually a really important part of medical care. But the idea that like about like good survey strategies is maybe not like really built into medical education, but they were sort of just handed the stack of surveys and be like, go survey every household. So I think there was also just kind of like they would sort of be like a frustration, like, why am I supposed to do this? I'm not trained to do this. I don't know what I'm doing with this. So there's a little bit of that element. But I think that the other sort of challenge is like even the way of framing questions was a little bit superficial and a little bit like kind of looking for the problem in the household rather than sort of what I think policymakers maybe initially hoped for these kinds of things, where they were like, well, we really have to think about, like um, kind of larger structural conditions. And the survey does address it a little bit. They'll sort of say, like, do you have access to running water, things like that, which, is a way to kind of say, um, actually drinkable water in this place, which, is kind of a big public health question, which is, perhaps you could argue is fair to ask in a survey to just get a sense of what the health concerns of a community are. But then a lot of the questions would really focus on this hyper individualizing, like, what do you eat? Like, what's your diet? How many people are sleeping in your room? How do you dispose of waste? This kind of stuff that like ends up becoming much more about like, how are you just living your daily life with your family? And is your relationship with your family functional? Is it not functional? Is it dysfunctional? Is it conflictive? And so part of it is like,
Mhm.
just the question was so focused on like it almost became this way of kind of blaming individuals and families for the health problems rather than maybe what was initially the intent of being like, let's look at these sort of socioeconomic factors, like if people have access to water, or like how far is the nearest health center, which is a little bit in there, but then kind of falls to the wayside with this just hyper focus on like, what are people doing in their daily lives and kind of surveilling them and being like, oh, what if you're doing it wrong? And then people kind of feel that pressure. But then also, again, it comes back to methodology. It's like not only are they not trained, but how on earth am I supposed to know if a family's functional or dysfunctional based on a 10-minute survey? Like it's a hard question to actually address, even if you want to know it. And I'm not sure that they especially through this kind of survey form. So I didn't really see the like kinship relations or asking people to be godparents as really interfering or complicating with the surveys in any way. I would say that was more like a separate practices, but that patients really wanted doctors and nurses to participate in. And then the doctors and nurses would sometimes be like, yeah, sure. And then sometimes they'd just be like, well, I don't really know you, but please fill out the survey, right? And it was increasingly kind of going to the latter. So it was more that the patients kind of saw the surveys as really inadequately helping them receive better care. And the doctors, frankly, saw it that way too, but they were sort of being expected to do this as part of their work. But it was kind of stopping them from thinking about like, what actually is my relationship with the patient? What's the patient asking for this relationship to be, if that makes sense.
Yes, so thank you. Thank you for answering. And it was really fascinating how you incorporated in your research how the how being padrino, madrina, godparents, and godmother like function in relation to health. So
Yeah.
would be really interested in hearing about your positionality with this and your experience when you were in the field.
Yeah, great question. And I think for me, I know we're kind of short on time, so I'll try to keep it brief. But for me, I was really pulled into this project, I think, in through a lot of complicated ways. But my father is from Bolivia, so I have a lot of family connections there. So I had been kind of spending a lot of time there anyway, and sort of like was very interested in kind of returning to do this project there. But then moved to a more rural area than where my family lived for kind of this portion of the research. And I was also kind of getting to kind of know many people in this area. And I will say my Bolivian family like would identify as probably mestizo, rather and not as indigenous. Whereas most people I was and I myself am, pretty white. So but when I was working in this area, like so it's in some ways I was like you know, working in a context that I was in some ways familiar with, and in some ways, still kind of learning and working to build relations and just trying to think about like what is my place doing this research, and like what's kind of my relationship to people, what kinds of forms of accountability do I want to create in this research as well. And kind of very early on, people would sometimes be like, "Hey, will you be the godparent to my kid, or will you be the godparent to the godmother to the graduating class?" This kinds of things. And so I was kind of and being kind of part of those sort of relationships. I came to kind of understand in two ways. So one is sort of thinking about when people were asking me to also participate in that way, to me, that's also a way of saying like, you actually need to be accountable to relationships here. You can't just like run off and disappear. Like you need to participate, you need to be helpful, you need to kind of actively be involved in people's lives. Which, I think is absolutely correct. So I think that was, part of that ask. And then others like being kind of perceived as someone who's like, okay, coming in from, a US university, potentially has some more resources, can kind of, like maybe might be a good person to ask. And so even things like, or, I would go work a lot in just kind of shadow doctors in the hospital a lot. And so people would be like, oh, we heard that you work in the hospital. Can you tell me what's like, how can I get better medical care? How can I get the doctors to listen to me? So, there's this kind of exchange going on as well, where people are like, oh, well, you're the godparents, so you can help us think about these sort of questions, or like help participate in this project of trying to get better medical care, which would usually happen kind of indirectly. Like I wasn't like, oh, here's how you do it, but just a sort of like, um, a sort of like answering questions, being sort of like sometimes accompanying people in the waiting room, this kind of thing. But but I think that also that kind of the ways that I myself was, also part of these relationships as people were asking me to be, really sort of shaped a lot of my thinking that I actually ended up doing in the research as well, because I was thinking a lot about like, what happens when we see a lot of patients also asking doctors to kind of participate in these relationships. And not every doctor said yes, but quite a few did. And understanding that's just like such an important part of these sort of local health worlds. But that kind of relational understanding of like, this is what makes good care, it's what makes the care better for me, in more ways than one. It's a little bit like ignored then by the government, which is just kind of like, yes, we want a relational understanding of care, but it's not always engaging with what that actually looks like on the ground for people when they're saying that. I don't know. It's very complicated. I think there's sort of multiple understandings of what having a relational understanding of care could even mean in this context. And I've only kind of just dipped my toe in, I think, in this talk. But it's just to say that these were very kind of central practices that, despite kind of all the stated intentions, were not really being taken up in something like the surveys or all these things that sort of claimed like we're going to create more relational care. So yeah.